As promised, tonight we speak to the Health Minister and we're asking if South Africa is starting to lose ground in the fight against HIV and AIDS. The Times recently reported that the United States plans to cut its funding for HIV treatment in South Africa by more than 5 billion rand, saying the fight against AIDS here is grossly suboptimal. The problem is that many people who start taking life-saving drugs, those ARVs, are not continuing with the treatment. South Africa, you'll recall, has the largest AIDS epidemic in the world, with more than 7 million people living with HIV here. Well, we're joined by the Health Minister, Aaron Motsoaledi. Thank you for being with us, Minister.
Thank you, Francis.
Can you confirm these figures that are being cited, that the US, which donated more than 10 billion over the last financial year, for the next financial year, talking about 5.7 billion. So that sounds like almost cutting the funding in half.
Well, there is a submission in the US which is done to Congress to cut on foreign aid, not only to South Africa. It's global. But that submission still have to go to Congress. So you can't conclude that they've already cut off any amount. And in our discussion with US, that decision will be taken not for this financial year, but for the next financial year if certain things do not happen. So, but let me explain, because I also heard you when you were introducing this program, even before I came in, about the issue of suboptimal performance. We still run the biggest HIV/AIDS program in the world. We've got 4.5 million people on ARVs. That's the biggest globally. We are putting 600,000 people on ARVs every single year. The problem we're faced with, what they are talking about, is that we have realized it our own and putting programs. After 6 months of putting people on treatment, 20% of them opt out of the treatment. That's the major issue, which is worrying everybody. In other words, you know that ARVs are lifelong in order to achieve viral suppression.
So that's 1 in 5. Why are they not continuing with treatment?
Well, there are quite a number of factors. The factors can be divided into, patient factors, but also into systemic, the program factors. That means the system of healthcare in our country, but also there are patient factors. Number one, there is treatment fatigue. There are people who just get fatigued because they must take these things for the rest of their lives every day. It just fatigues them. But the others will tell you that, look, I've been to the clinic and there are too many, there are long queues. I wait for too long in the clinic and I don't have time for that. Others will say, I defaulted for a few months and I'm afraid to go back because I've heard that people who have defaulted are scolded when they go back, So I'm afraid that something like that will happen to me. Some men will say, look, I've just got a new job and I don't have time to go to the clinic to continue, So there are quite a number of factors that people put forward why they don't continue treatment.
So you've raised some big issues here, and from what I can tell, the US also saying one of the big things is the waiting times at clinics.
Yeah.
So if you are a young person, you've got a job, you can't become unemployed because you're sitting in a clinic all day. This is also being raised in connection with the probe by the Human Rights Commission. Minister, what are you doing personally about those waiting times in clinics?
Well, we've done quite a lot of things. And we have started long ago, it's not now. First of all, we have to ask ourselves, why are there long waiting times? And why are they increasing? You have got to answer that question before you come up with solutions. Number one, if you look at perhaps 15 years back, let me say, in 2004, if you go back to 2004, we only have 400,000 people who are on ARVs. In 2009, when we decided to up our program in South Africa, we have 923,000 people on ARVs. Today, you have got 4.5 million using the same health facilities, perhaps with more or less the same health workers. So the waiting times have to increase. So, yes, because we have got more and more people coming.
However, isn't this about allocation of resources? You can project those things. In Gauteng, they're saying the same thing. A doctor's saying there's a critical shortage of nurses and doctors.
But we've never denied that.
Are we not planning for all of this?
No. It's not about planning. I've mentioned it many times, Francis. The public health care system, when the economy started tankering, lost 9 billion rand in a period of 3 years. We lost 9 billion rand. And most of that money was lost for human resources and infrastructure and equipment. Whereas within the same period, the private sector gained 11 billion because it's statutory things in medical aids. That's why we need to change that gross inequality urgently, and that's why we're talking about NHI to change that. So we know about those shortages now, but while we know about that, there are other programs we are putting. For instance, we've came up with a program of CCMDD, Central Chronic Medication Distribution and Dispensing, where we are saying, because we keep on adding, you are adding 600,000 people every year. Next year is another 600,000. Next year, the rate at which you invest in staff and all that in this economic climate is very difficult to catch up. So what we are doing is, we've come up with that program where we're saying those people who are stable, who don't have to be seen by a doctor, just go in there to queue to receive their medicines. Let them receive them elsewhere. In other words, give us a place next to their home where they don't have to travel. Because I also forgot, some of them say, look, I don't have money to travel to the clinic. Now with the petrol rises and all that, that will even become worse. So we say, let's carry the medicines where they are. Now, at the moment, we've got 2.8 million South Africans who don't have to go to a clinic or hospital to queue there. It could have been worse in other ways if we added those 2.8. But they give us an address where they'll go and collect their medicines. We've got a service provider who take those addresses and go and supply the medicine there. That's the first thing that we are doing. The second thing, we looked in the filing system. We found that in most of our clinics, people spend this long period, which you say long queues, né? They spend it waiting for a file, waiting for a file because the files are put in such a way that it's difficult to find a file. So we are also helping with the filing system. Others is just, when you have got many people, let's say in a bank or what, you have got to have a method of how to deal with large crowds. And some of our health centers, facilities, we're not doing that. We are now seeing them. Tomorrow I'm starting a visit. And I'm starting in I'm visiting all provinces. In each visit, I call every CEO of a hospital. I call every clinical manager. I call every nursing manager. I call every director of a district. I call every HAST manager. HAST are people who are running HIV, AIDS, and TB programs. To outline some of these steps that when you are running a big program like the one we are running, you are likely to get into problems if you do certain things that are extra than what you're doing. For instance, you're putting more people on treatment than any country. Obviously, the number of people who get fatigue or who drop out or who default will also increase. You need to have a special plan to do that.
When you're there, do you speak to the nurses themselves? Because that seems an issue that we hear over and over again, the attitude of nurses. Young people saying that they feel like they'll be judged. Teenagers will be judged by the people serving them. And this is so bad that some people will come off life-saving drugs so that they don't have to deal with those nurses.
Well, that's ongoing. It's not going to be possible for me to meet each and every nurse, but we put them in programs. For instance, in 2009, we had only 400 nurses in this country who were trained in what we call NIRMAT, nurse-initiated antiretroviral treatment, where there's no doctor. Once you are found to be HIV positive, the nurse can prescribe for you in the absence of a doctor. We have increased those nurses to 23,000 from 400 in 2009 to 23,000 now. They are trained, and part of the message I'm going to be giving to the leaders, which they must take to their hospitals, is tomorrow, the leaders I'm going to meet over the next 2 weeks, is to inform them that it doesn't help the country that when somebody has defaulted, you come and scold at them and all that, because they'll simply go away on a disease that is destroying the country. So we are going to teach them to have a better attitude towards them. But we are also going to launch a special program, which we call, to bring them back. Just in February alone, when we started that program, we're able to find 25,000 people who have stopped treatment, We're also going to use community health workers to trace them. We'll even give them a target and say, each community health worker, if you can target and trace so many people, yes.
I guess the big question here, Minister, you mentioned the NHI, and everyone knows that is your passion project. But in the meantime, it's about affordable healthcare for all, which is very compelling. But in the meantime, we have this big public hospital system that is meant to help anyone who arrives. Things are in such disarray that we have the Human Rights Commission stepping in. Are we thinking about the future as well as the now? Is enough being done about our health problems now?
Well, I thought I've just given you the answer, Francis.
You have, but we've been talking about the same things for a very long time.
Not the same things for a very long time. People keep on quoting this and running away from the basics. We are the only country which is spending so much money for so few people. Those are not my words, they are words of the World Organization. We're spending too much money on few people and telling the lots of people that please improve yourself. It's like what happened during the apartheid era in education, where 4 times more was spent on a white child than a black child. But then you keep on saying, no, the black kids must also improve, they must do their best and all that, when the resources are actually taken away from them. So we are not talking theory. When we say 4.5% of the GDP on health in South Africa is spent on only 16% of the population, and the remaining 4.2% is spent on 84% of the population. Those are the masses, and we are saying, go and improve them. Yes, we are prepared to improve them, we've got plans, but you need resources to do that. And you can't keep on throwing resources. For instance, that 80% of the specialists in this country are in the private sector, saving only that 16% of the population. We have got an explosion of mental health, because it's not only HIV/AIDS, mental health, cancer, diabetes. But when you look at the resources and the staffing, they've been put for the elite, for us who have got medical aid. Now, NHI is going to change that system, because without changing that system, we'll keep on struggling.
Right now, so you're talking about this inequality. You're also raising issues like logistics, like people looking for files, administrative issues. Can't you get the private sector on board now? People are coming up with solutions for things like that.
No, we are putting up solutions, whether they're in the private sector or the public sector. We are putting up the solutions. For instance, we have worked for the past 3 years with CSIR, the Department of Science and Technology, and Home Affairs, to come up with what we call health patients registration system, where we are changing even the filing system, the recording system. We have got a team of 25 people who are skilled in that. And they've been moving from province to province, but we started in clinics. And I think they've just completed about 2,900 clinics. It's a lot of work, because in some instances they found that they've got to change the infrastructure even before they put that system. So we are busy doing that. In some instances, it just needs a little investment, like we have done it already in some few clinics where you find that. But this manager, for instance, some of the managers just fold their arms and say, we're waiting for this new system in national. But you show them that, look, you can put a small shelf there, and So some of them it's just lack of initiative, and that's what I will be telling them tomorrow, that we have got to have initiative. Others, where we discovered the problem with the filing system, when patients realize that, if they take long to find my file, the best thing is that when I arrive there, I must say I'm new. So we have discovered people who just come and say, I've never been here before, in order to get the quick file. Others even change their names and get a new file with a different name. So now that's losing a lot of records and all that. So we are also training data capturers to try and capture this data. So it's a whole lot of solutions that we are putting up. But the fact remains that those problems are manifesting themselves because you are running the world's biggest program, which exists nowhere because we have got the largest number of people who are infected in the whole world.
What are the implications for that program if this funding is cut, if we lose 4 billion rand because of the US?
Well, the lucky thing, which we should know, is that we suspected this for a long time. Unlike other countries on the continent, we wanted to depend on ourselves. 80% of our HIV funding is from our own resources here in South Africa. So it's 20% which is being funded by donors. It will have an effect on us, but we are trying to emphasize that we are own finding be self-sufficient. And we've been told that the 80% that we are doing is unprecedented on the whole continent. It's because, you know, if you depend on foreign funding, they can look for any excuse to take it back. We are aware that there are problems in the US in terms of the new policies of, you know, President Donald Trump himself even once said, I'm not going to fund anybody who opposes me. Anybody who opposes my policies, I'm not going to fund them. I mean, that you know, is part of global politics. You know?
In terms of our own goals, President Ramaphosa said we want to get to a situation where there will be 6.1 people, that's 2 million patients more, I think, getting ARVs by 2020.
Yeah.
But if people are dropping off, stopping taking the drugs, is that goal now possible?
Yes, it is possible. Because I think you must differentiate here. We are able to get people because we are testing 13 million people every year in South Africa. Out of that 13 million people we are testing, we are putting 600,000 on treatment. And we have discovered that 20% of them drop off. So our concentration is on those who are dropping off, if you understand what I mean. That's the second thing is that most of the people who come and test and know their status are women. Men are staying away. And some of them...
Why?
Well, they give many reasons. If you go to our clinics, mostly you'll find women. They will tell you that they are working. Most of them are at work. So one of the strategies is to open after hours for them, or even during weekends. We have already developed some of those strategies. We have written to provinces to start looking into areas where they can say this particular clinic, all the men who are working can come after hours, etc. The other strategies I've told you is the chronic medication, where they must choose an area where they can work even after hours to collect their medicine. So we are putting up a whole lot of possibilities to solve this huge program.
For me, one of the tragedies is that doctors and your department is talking about this phenomena where the drugs can make you, what is it? You're free, basically, of the virus.
They can make you what?
You're free of the virus. In fact, you can't pass on the virus. Your viral load
yes.
Is completely undetectable. So you can't pass on the virus. This is such good news. Is it just not getting out there to people who can live healthy lives?
We're actually going to teach people a small mathematical formula. U is equal to U, meaning undetected is also equal to untransmitted. Once your viral load is undetected, it's untransmitted. But if you remember, the International Society AIDS Conference in Melbourne in Australia in 2014 said, the world can reach that through 1990. If you reach the formula of 1990, then you can reach that level we are talking about, where the viral load is undetected and cannot be transmitted. And what does 1990 mean? It means you put 90% of the people, firstly you find 90% of the people who are infected in your country. You know, it's estimated that South Africa has got 7.2 million people who are infected. Find 90% of them. That's the first 90. That's why we are testing 13 million people per annum to look for that 90. Then the second 90 is after finding them, put 90% of them on treatment. That's why the president said add 2 million people, because we are at 4.5. If we add 2 million people, we'll be at 6.5, and that's our second 90. The last 90 is if they keep on taking their treatment, then they'll be virally suppressed. and undetected. And once it's undetected and suppressed, then it can't be transmitted.
So that's our formula. They have to stay on treatment, which is the problem we're talking about.
Which is the problem we're talking about,
We're running out of time, Minister. What's happening with TB? Because that is also a concern for you, people not wanting to go on the drugs, not wanting to find out even that they've got TB.
Well, TB were quite advanced. I'm sure you might have heard that we are regarded as one of the countries that, I mean, even by the Lancet Commission. You are aware that the Lancet and Harvard have put together a program of set up a commission, and I was one of the commissioners. Last week we released the results. Most of the recommendations there they've made, South Africa is already doing them. For instance, we know that the high-level meeting of heads of states in New York in 2017, September, had 5 decisions which they took. One of them is we must find the missing people around the world who have got TB but who are not on treatment. There are 10 million people infected with TB. 6 million are on treatment. The other 4 million are missing. South Africa has got its fair share of that missing 4 million. It's estimated at 160,000. We said we are going to find at least 80 million. Between April and December last year, we've already traced 38,000 who have got TB, and we put them on treatment. And we're still continuing to go and find more. By visiting people who are contacts, anybody who has got TB, we got to visit them in their family and screen the whole family members. That's how we got the 38,000 people.
I have time for only one more question. Your passion project, the NHI, we've heard about Obamacare in the US. You've been talking recently about Ramaphosa Care. Is the president giving the backing that you've asked for here to make this happen?
It's not me who spoke about Ramaphosa Care. I was asked by a journalist. It's only that sometimes in journalism you add biases. I was asked why the president has taken over NHI in the form of a war room. And I said, I asked him, because internationally, this program of universal health coverage is huge. It's usually run by a head of state because it affects all the other government departments. And I gave an example that in the US, for instance, it's nicknamed Obamacare. Its name is Affordable Health Care. But the journalists there nicknamed it, the media nicknamed Obamacare because
so
it's Obama.
Do you mind the dubbing, Ramaphosa Care?
No, then the journalist asked me, so in South Africa, should we call it Ramaphosa Care? I said, it's up to you. There's nothing wrong with that. But the report came out as if I'm the one who say I'm naming it Ramaphosa Care.
All right.
I said, if they want to nickname it like that, like the media in America, I don't see anything wrong.
All right, let's see if it evolves into its own sort of nickname like it did in the US. Thank you for your time this evening, Health Minister Aaron Motsoaledi.